Thank you for having me. I am Amy Falk. I'm a pediatrician at the Aspirus Doctors Clinic, and I was asked to give grand rounds today regarding my work in the schools with COVID-19. We're calling it Community COVID in the Classroom, a Pediatrician's Tale. I'm an alumna of UW-Madison Pediatric Residency, and as I said, General Peds down here. So I have nothing to disclose as far as any sort of conflicts of interest. So learning objectives would be to identify areas in your community that could benefit from your knowledge and expertise. Number two, demonstrate how to engage with partners and other stakeholders in community-based public health efforts. And finally, to describe how you can create a plan to impact the lives of kids in your community. So a brief overview will be that I'll give a background of kind of what our work was last school year and the K-12 research that we were able to do, including covering the MMWR study that I was able to publish, our surveillance testing, which is in pre-publication review right now, and also what's next for my group. And when I say group, I mean myself and a med student. And hopefully giving the second half of the presentation will be some ways that perhaps you can get involved with examples of how we did what we did. So as a brief background, it all started when Dr. Olson, a family medicine doctor here, and one of my good friends and I decided that we wanted to help some schools with planning for the 2020-2021 school year. It also started as I pursued getting a grant for children to have free masks that were high quality for 8,000 kids in Southwood County. And as a result of that, I wanted to show the Legacy Foundation, the people who gave the grant for the masks, that their funds were being utilized during the pandemic response. So this included weekly teacher masking surveys, and I'll give a little example of what that is, as well as collecting information from schools about the COVID-19 cases and where they think they came from. I really never intended for this to be a study or to be published. It's essentially quality improvement, I guess, as the school year rolled on. But we knew that once we were getting a lot of these results, and it was around Halloween or Thanksgiving, we had something really special in the very strange climate that was last year. So I have zero research experience. I have zero resources. My team was a couple of medical students, a wayward optometrist, my husband who knows his way around some spreadsheets. And then way late in the game, we found an MD PhD to help us with manuscript development. And I really had no university or large medical system support. So the CDC MMWR thing. So and I'll tell you a little bit about the study period, which was from the start of school year to Thanksgiving last year, where we watched masking compliance as well as in-school COVID-19 cases. And all of these schools down here in Southwood County, they were all beneficiaries of this of the masking grant. They all used masks to some degree. They all had some type of keeping kids together type cohorts. Sometimes that was hybrid. Sometimes that was just keeping each elementary school class together. The staff was to maintain 6 feet of distance if possible, though this was a relaxed and unmeasured metric. And then they were quarantining after exposures. And so masking compliance was very high. More than 92% use of the students were wearing masks during our snapshot surveys. And then during our 13 weeks of in-person learning, there were only 7 student cases of COVID-19 and 0 among staff that were known to have been contracted during the school hours. And there was no spread to or from staff, despite extremely high community percent positivity, up to 40%, which is obviously wild. So this is the infographic that the CDC made. It was a crazy ride. But it really helped. This published around the same time that Duke's University study published in, I believe, JAMA Peds, that showed exactly the same thing with a much larger data set. So together, it was some of the first data to be able to help open schools last year. So our study population, a lot of you know this, that's where we are. So this included 17 schools in Southwood County across 4 districts, public and parochial. They were all beneficiaries of the grant to purchase masks for their children to use. It all started in person in some way, sometimes hybrid, as I mentioned. We selected only 17 of the schools that were involved just because arbitrarily I didn't think I could handle much larger of a data set, not because I made any significant selection in that way. Our N was 5,530, which included, 1,500 elementary kids, 3,300 secondary kids, which is we counted as grades 6 to 12, teachers and staff about 654. Our population in Wood County, about 73,000, 92% white and non-Hispanic, poverty threshold 10.7%. And this was important for the CDC, especially through our many rounds of editing and kind of revisions. They were really reluctant. Some groups were very reluctant because of our very non-diverse population as far as generalizability, but it still got through, and I can't apologize for my county. So what did we find? Briefly, over 13 weeks of the study period, again from September 1st to around Thanksgiving, there were 191 cases in students and staff, 133 in students, the rest in staff, and only 7 were thought to be attributable to in-school spread, and they were all kids. So this was done by contact tracing through school admin, teachers, parents, and public health. Which obviously is a lower level of evidence, but at that time, testing was really not as robust as it is now. We obviously still aren't doing genomic testing to sort of figure out where the cases were coming from. So a lot of limitations there, but there you have it. That's what we did. So all of these were kids, 5 elementary kids, 2 middle school, no staff that had thought that to be contracted in school. And of the 5 elementary kids, there was one cluster of 3 boys who ate lunch together. So obviously lunch would be a higher risk time as they're maybe distance a tiny bit, but not nearly as, and their masks are off and talking and laughing, whatever. So that's considered to be a higher risk activity anyhow. And then these 3 boys, they ate lunch together, but they also played outside of school as well too together. So kind of a unsure where they got it from, but we did count it as one of our 7 in-school spread. Oops, going back. So this is one of the published graphs. It's a little disorienting to start, but on the bottom axis is weeks over time. And then you can see on the left y-axis cases per 100,000. The blue line would be cases in our county per 100,000. And then the red line, school cases per 100,000. Obviously, it's a little confusing because the school cases would clearly be counted in county cases, but for the purpose of this graph, I think it does okay. And on the right axis, y-axis, there is the county percent positivity, which is percent of all tests run that ended up being positive in our county. So the green line alone was bonkers. Like, a lot of the metrics last year when they were using metrics in the community for school opening, which has fallen out of favor. This is nuts. In October when we were all overrun, there was a body truck at, Marshfield. And then, so you can see the blue line and the red line really do mirror each other. Both increased sharply when we had the most percent positivity, but the red line, the school line of cases, does not outpace the community. So we were able to infer that perhaps the school cases were coming from the community, especially with their contact tracing data, and that schools were not driving community spread, which, as we all remember, was one of the major concerns about having in-person learning, if these kids were going to be vectors and hurt all of our old people or everyone else prior to the vaccination. So regarding masking and absences, masking compliance among all students for all age groups for the 13 weeks was reported to be 92% on average. And we thought student absences might be correlated in part to community case numbers. So the survey we sent to teachers, or the school admin would send to teachers, depending on the school kind of preference, the survey is extraordinarily short. So it's what grade are you teaching? How many kids are supposed to be here today? So what is the total N? How many kids are here today? And that difference would be the absent percentage of kids not there. And then how many kids were masked when expected to do so? And we define that as they're going to be close together, or, any of the CDC requirements for masking at that time. And so we were able to generate percentages for absences and masking compliance. Obviously, this is reliant on teacher objectivity, kind of being able to tell us what's going on. It's relying on them to do the survey. We had approximately 55% survey compliance rate overall. Some schools worked much better than others. And then we also had an area for comments that we would attempt to address weekly, which I'll talk about a little later. So that's sort of what we found. This is also published data from our study. So, I mean, a very simple graph, but showing that more than 90% of students were masked on average throughout the entire study period, showing very high masking compliances. As you may know, masking compliance of a community or a school greater than 80, sometimes 85% is cited to be as good as a lockdown, staying home. So if you can cover up most people's, way to be a vector for germs, that seems to be protective. So this is a little different of a graph, but we wanted to show how good each grade level was. So this is the percent unmasked. So how many kids were not wearing a mask? Elementary kids are the blue line, secondary, the red line. And there was a lot of thought early, like, okay, the little kids are going to be terrible at masking because they're little, or the big kids are going to be terrible at masking because they're teenagers. But really, we found that both were quite good. Both got sick of it towards the end, a little bit higher unmasked percentages around, the middle to end of our study period, but overall still in a protective range there. So showing that overall little kids are good at masking when there's a mandate, big kids are good at masking, and things went well that way. So these are unpublished graphs, but something we were able to generate and send to the schools and kind of work with. So the top left is how community COVID relates to school absences. And both of these graphs are extremely fraught with confounders, like kids' absences can be due to lots of different things. But overall, we did show a trend. So as total COVID community spread happened, so the blue line, the more COVID cases we had, which was exponential. Towards the end of the study, we saw more school absences. Up to 20% of kids were gone at any given time, reported to us. And I have zero statistical ability, but I remembered something about an R squared. So I was able to generate the right graph here. So if you plot total COVID on the bottom x-axis, school absences on the y-axis, plot all those points and try to have the computer make a line to connect them all. R squared would be how good does that line fit all those points? And so it's a score of 0 to 1. The closer to 1 you are, the better fit that is. So that trend line for us was R squared was 0.88. So did show a pretty positive correlation between total COVID in the community, how bad was COVID in your community versus school absences. So that was the whole CDC MMWR thing. Again, it was rounds and rounds and rounds of editing. Even after we were accepted, it was kind of a wild process, but I really think it made a difference kind of in that late winter time when a lot of schools were grappling with what to do. So I think I hope that was helpful. Our next piece we wanted to do was surveillance testing. I kind of pushed for this. Obviously, surveillance testing has been found to be cumbersome and maybe not quite as useful, but back in late winter, early spring, our high school, the WRPS high school, was in a hybrid model, and meaning the kids were going to school 2 days a week and virtual the rest of the time. And this is really cumbersome. A lot of kids were struggling. We know in-person learning is superior to hybrid or virtual. And so we kind of all powwowed again. And I said, how do we get these kids back in? What if we did surveillance testing as we brought them all back into the building when distancing would not be possible? So we developed a survey PCR program at the middle and high school at the WRPS, or Wisconsin Rapids Public School District. Our N was 2,288. We received grant funding from the Legacy Foundation, again, the same people who did the masks, to be able to purchase the PCR tests. Rapid tests, as you may know, rapid antigen tests have very poor sensitivity and specificity, especially in asymptomatic adolescents. So for a screening tool, I didn't want to rely on that. And our state health department, after several meetings with them, were unwilling or unable to supply us with the testing with quick enough turnaround. So we went our own way. And Aspirus was extremely helpful in this. I will say they were the ones who kind of worked with us in the school district as far as being able to run those and doing it for cost essentially. So we did this surveillance program transitioning from 2 days a week to hybrid to a 5-day a week in person, with obviously, if you bring in a total student body of adolescents, decreased ability to distance, again, at a time when no teachers were vaccinated. So there was quite a bit of worry about doing this. There was still the mandatory masking as put forth by the WRPS school board. So what did we find in a nutshell? Student percent positivity at any given time of these asymptomatic people who volunteered to do this study was about 3% on average, ranging from 0 to 16.2%. There's one massive outlier week that was very confusing. I will show you. And teacher percent positivity, 1.72 on average, ranging from 0 to around 7%. So we were able to show generally low in school despite distancing ability. And one of our major troubles with this, and reason that we're not doing it anymore for this school year, is that we had extraordinarily low participation rate. So very few students and teachers consented to doing this, maybe only 15% of our population. And so that obviously significantly reduces our ability to generalize these results to the rest of the school. So this graph, all these findings are in under consideration at a journal right now. The process is taking quite a while. It's been under consideration for about 3 months now. So this is figure 1 from that paper, showing that. So the bright blue line is percent of students and staff who consented to be tested. So we would, so obviously they needed to be consented. We couldn't just grab kids from math class for it. And it was extremely low. So my dream when we were sort of like, figuring out how to do this, I was speaking with Duke and Madison to kind of help, and they're like, you should test about 20% of people weekly. That would be good. We couldn't even get that percentage of people to consent. And that did decrease over time. As you can see, we ended up with about 13% of the total student and staff body consenting. And as far as the purple line is percent tested of the total school population, is very low as well. So we had a couple good weeks where we were testing about 12% of the student body, which then completely fell off. We were testing around 5%. So in order to do this, I will say it was extremely difficult from a logistics standpoint. School nursing and school staff did not have the bandwidth to do this type of surveillance testing. So I found 8 volunteers who ended up being able to get the vaccine slightly earlier than the rest of the community, were PPE fit tested and all that type of stuff for kind of being able to do it. So it required many volunteer hours, obviously some administrative time to run through the results and kind of deal with that. So logistically, it was a disaster for not much yield. So this graph is kind of interesting. And obviously, the thing that sticks out is this massive increase in asymptomatic cases. But to orient you briefly, on the bottom axis, obviously, is weeks, new school cases. And then we differentiated between asymptomatic cases in the teal, which would be the surveillance testing, and then symptomatic cases in the darker blue. And those would be children or staff who got testing elsewhere. The schools were doing testing as well, too. If kids were symptomatic, could get PCR testing through the school system. So basically how many kids were positive, and teachers too, for having symptoms. And so the first several weeks, and then the red line is percent positivity of our PCR surveillance testing only. So as you can see, the blue lines, the dark blue remains really consistent. So we did have a slight uptick to 4 cases per week, but out of an N of 2,000 some, obviously not a significant number of cases. So if we hadn't been doing surveillance testing, we wouldn't have found this massive increase. Now, what happened here? So weeks 1 through 3, we had hybrid learning. So these kids were able to distance a little more, and I'll show that briefly. And then after week 4, we went all in, so full on student body. Week 6 is spring break. This is also when the Wisconsin mask mandate fell. So interestingly, we came back from spring break, which was week 7, and did our surveillance testing as usual. And then that weekend between 7 and 8, all the results came in, and it was like this red alert meeting with school admin, myself, public health, Dr. Olson, trying to figure out what do we do. These 19 cases we found were all in students, and they were split equally between the 2 schools. None of them admitted to travel, so nobody traveled during spring break. really nothing weird going on. One person might have went to the Dells. And so it was sort of like, where did this come from? Is this the canary in the coal mine for the community? But our symptomatic cases really didn't change much at all. And then things really settled down the next few weeks. So Madison had recommended, hey, do you go virtual for a while to let this settle down, get these kids out of school? We chose to just sort of see what the next week showed, which came back much closer to the baseline number. So we ended up making no changes, keeping all the kids in school, getting these kids out, obviously. So we did, the intervention was helpful. We pulled those 19 kids who did have virus in their nose, but ended up having 0 symptoms, got them out of school. Did they save future cases? Maybe. So in the end, we made no changes aside from getting those kids out, and we finished the school year very strong as far as number of cases, both symptomatic and asymptomatic. So this is what our community was doing during this time. So as you might remember, kind of late February, early March, things were fine. Interestingly, I had to explain away week 2. So things were so slow at the public health department late February that they did some auditing of their records from the huge surge from the fall, and they found that 5 cases were classified as about 10 cases, I guess, were classified as cases instead of probable. So that could be that people had a rapid antigen test but no follow-up PCR. So they should have been a probable. So they took away a bunch of cases from the overall pot of cases, making it look like we had negative COVID cases that week. So anyway, it just kind of looks weird, but that's what happened. It's just an auditing error there. And as you can see, things kind of heated up a little bit. As you might remember, week 7 is when we had that big surge. Community percent of asymptomatics, community percent positivity was around 10% at that time, and kind of settled out, was still nothing, and we did well. And then finally, what was distancing like at the middle and high school? Middle school is the dark blue bar, high school is the light blue bars. So weeks 1 through 3, we had the hybrid model where there was only half of the school in session at a given time. And the high school did a good job of maintaining that recommended 6-foot distance overall. Middle school a little bit less, but still fine. And then weeks 4 and on, we obviously were full cohort there, so full student population. And then maintaining closer to that 3-foot, they were able to maintain that at this age level. So what are we up to this year? So by we, I mean myself and one medical student. We're going to continue to monitor COVID-19 cases and subsequent in-school spread. I am now working with, so Duke University, the ABC group is what they call themselves, with Duke's horsepower behind it, is organizing like a nationwide monitoring of the situation, because there's obviously going to be soup to nuts in terms of mitigation measures and quarantines, with some schools doing nothing, including bringing kids back who are COVID positive, as long as they don't have fever, to full quarantines, mask mandates. So the majority of schools in our area are going to be mask optional. We strongly suspect more in-school spread this year, which we may not detect if schools are not making people get tested. Last night, the school board voted at WRPS. They completely flipped their vote. They were anticipating a preliminary vote was 6-1 mask optional for all age groups. And because Dr. Olson and I are extremely persistent and presented a case study of fairly significant in-person spread at the Boys and Girls Club, they did flip their decision. So there will be mask mandate at WRPS for 4K through 8th grade. Additionally, we have the added challenge of the Delta variant, which is extraordinarily more contagious. I'm sure you guys are aware that the R naught, or the infectivity for Delta, is 7 to 9. So each infected person infects 7 to 9 more people, compared to the original wild type, which was an R naught of 1 to 2. And Delta seems to like little kids, probably because it's more infectious. So that's the study part. And to conclude here, I wanted to explain how I got into this mess, or how you can jump into a cause you might care about too, and how you can perhaps get involved in your community. So when I thought about this presentation, I was thinking about different, I guess, buckets of ways to help in your community, and then how to fit in my example as to sort of demonstrate that. So I feel like the most important thing to do is identify what matters to you. So what in your community, what in your practice or your system needs work. So there's obstacles everywhere. I felt like I was wading through cement the majority of the time, but I really wanted to advocate for my children. So those are my three kids. The two boys are going to be in second grade and 4K at WRPS. So I obviously have significant unvaccinated skin in the game. The little 2-year-old will be happy at home for the next year or two, but contracting whatever her brothers bring home. So for this project, my impetus is those guys, and all my patients, obviously. So something that we did, by we, I mean Dr. Olson and I, we really wanted to reach out to our community and help them understand what was going on. So very early in March 2020, we wrote co-posts on our Facebook, and it was just for our friends and neighbors. Ended up making a lot of them public, and we had over 15 Facebook posts where we would just share, kind of demystify stuff, kind of be able to explain what our community was seeing and what this meant and why masks were important and how they worked. One of our posts in September got over 3,600 shares, which I know is nothing in the age of TikTok, but for us old moms who were doing this was a big deal, and it was all over the world. It was very interesting. We directed these at our community members to try to give them easy to digest, up-to-date information. And we had lots and lots of feedback that people trusted our posts more than information from very large organizations like the CDC or the AAP, because they knew us. And I think that's an important thing to remember. Dr. Liebert and I always talk about, the lowest quality evidence is expert opinion. And that's essentially what Dr. Olson and I were doing. So for us physicians and providers, obviously, my word as a quote expert means much less than a meta-analysis, but that's what people know and understand. So for you to be an advocate and for you to say things matter really makes a difference as a physician, for sure. And another thing we learned was remembering that we represent our organization, Aspirus, even on our personal Facebook page. So we ended up clearing all posts with Aspirus PR. They were very helpful. Just wanted to make sure everything was kosher. But Dr. Olson and I really always tried to be nonpartisan, evidence-based, obviously at a time when it's very hard to do that. So that was kind of our goal all along, and Aspirus was pleased with that, but we did play the PR game that way. So I think even our pictures tell a story, and we talk about this all the time, like the picture we would put along with our post, for example, this one, we made a huge effort to distance the first one 6 feet apart. I have shield and mask, we're in scrubs. We obviously are still wearing shields and masks, but things were a little different. I posted this picture, the middle picture of my children, demonstrating that the less than 2-year-old baby here, she is not wearing a mask because she doesn't have to, because she's little, but the boys, we wanted to go to the library or wherever we were, and they had no trouble masking. The 3-year-old, had no trouble keeping that on his face, and he did really great. So just using that as an example that masking my children doesn't hurt them. And then finally, after Dr. Olson and I were vaccinated, we took this picture. We're closer together, no masks. We have our vaccinated shirts there. So trying to advocate that we believe is the wrong word, that we really feel strongly about these types of getting vaccinated and taking care of our community. So another thing that I think we could do as providers and physicians is answering the call. So like, who needs help? Who needs your help in the community, and what can you do? So the public school district asked Dr. Olson and I early to be medical advisors for their reopening plans. They told us, oh, it's going to be just a couple of meetings. That's all you need to do. The goal was get kids back in school and figure out how to do it. And as a result, Dr. Olson and I compiled emerging evidence, because as you remember, back in last spring and summer, we knew really not a lot about what COVID would do with kids and how it was transmitted and those sorts of things. So there was a lot of preliminary evidence from the peds infectious disease world that kids seem to be less likely than adults to contract and spread the virus. Obviously, Delta has completely changed the game, but back with wild type, that was more thought to be the case. And the more we thought about it, masking with other mitigation seemed absolutely critical. And it was not really thought to be important or something that was wanted to be pursued. And it was an extreme uphill battle. It still is. The anti-masking sentiment right from the start that continues today is alive and well. And so it's really hard to argue with people who think that we are committing child abuse by by making kids mask in school. So that was something we did end up having some difficulty with. So how did this all really start? I was on a bike ride last summer and I said, what if we need to find a way to get these kids masks? Because I knew, if Evan Falk, my kid, has nice masks and some other kids have something grandma made and some other kid doesn't bring anything, how can we make equitable supplies available to everybody? So I said, I got to buy all these kids masks. How am I going to do it? I called the Legacy Foundation. My father is on the board, who agreed to hear the case and said, hey, write up a grant and we'll talk about it. I had no idea how to write a grant. I literally Googled, how do you write a grant? So I wrote one and got $150,000 grant to buy masks for all students in Southwood County. More than 8,000 students are covered over 5 districts. At the end of this meeting, they said, hey, how are you going to show us that these aren't just going to sit in a closet? And I thought a little bit and I said, I'm going to study it. I'm going to demonstrate that there is mask usage. So the nonprofit board member, the Arrow guy, this is my husband, Peter. This is my father, who's my best reality check and critic. He's like, how are you going to run a study like this? You can't do this. And he's not wrong. I have zero track record. I've never done research. I did the bare minimum projects in med school and residency to make it through. I'm a clinician. Like, I take care of kids in my clinic and the hospital. That's what I like to do. And I have no idea about any of that. So obviously, that's the best challenge in the world, is when someone says you can't do something. So I enlisted a lot of help. My most plentiful resource, and usually still is my medical students. So a lot of them got very excited about this, helped me with data collection. We did all the stats by ourselves. My optometrist husband knows his way around a spreadsheet, so he was, third author on this thing. A couple of doctors that I would bounce stuff off of as far as ideas, and eventually a few academics got on board, but it was very late in the game. And I don't mean to say that they weren't helpful, but at that time we were all kind of in our silos, and I had a lot of the work done at that point. So another thing I think you can do is to show people what you're talking about, instead of just talking about it. So interestingly, there was summer school that was in session last summer, 2020. And at first there was 4 weeks of summer school and my kid was a part of it too. And obviously summer school is a little different, a little more low key. And at first, for the first 3 weeks, it was mask optional. So very strong recommendation from the summer school principal. I wrote an official doctorly letter to the family that was sent by admin saying, hey, let's keep the fun up. Here's why masking is important. Just send a mask with your kid. It's all good. And so I collected data on that to start, and I learned how to manage a data set this way. But the first week of summer school, we asked the teachers, hey, how many kids are masking? And as you can see, masking compliance at the bottom was extremely low. So like 0 to 25% was where the lion's share kind of landed. And this is what we saw for weeks 1, 2, 3. And then week 4 of summer school, this was around the time of the mask mandate from the governor there. And this is what happened. Boom. All of a sudden we had like almost 100% of kids masked in these classrooms. And so we were able to show the school board, look, if you do mask optional, honest to God, this is what you're going to get. You're going to get nothing, because we have this from our community. And if there's a mask mandate, for better or for worse, and we can argue about that, but it works and people put masks on their face. So that is one way we were able to demonstrate what we were talking about and honking about this masking compliance, by showing them real-time community data. So something else I learned to do was perhaps reach out to people in the right places. So who in your community might have resources that can be helpful to you, and what do you say? So you say, here's a problem I'm seeing or that I'm encountering in my practice or in my community. And then how can I help? I want to help. I'm not sure how. Maybe you have some ideas on how to get started, and offer to collaborate. And I think that's something that Dr. Olson and I tried to do right away. So we developed really close relationships with public health and the school superintendents, being available to them. We got to know hospital leadership, hospital PR sources. And then we put ourselves out there with a lot of speaking engagements. So early in the summer, we spoke with a lot of student groups, including athlete leaders, where we actually put them all in the bleachers at Lincoln, all the captains of all the different teams, all their coaches, and said, you may not be able to influence the entire school, but what you guys do matters to a lot of people. So what if you masked? What if you could keep playing football? What if we want to shut you down all the dang time because of spread? Like just put a mask on, encourage others to razz the freshmen about it and kind of do some of that stuff. And we got a ton of buy-in from athlete leaders early on. We spoke with the Boys and Girls Club, a lot of community leadership groups, including the Heart of Wisconsin. That was in November where the sheriff was there. And that was he said that was the first time he'd ever heard anything about why masks were important and some of the very basic clinical data that we sort of know we were able to translate. And I think we opened a lot of people's eyes at a time when it was really bad. We also spoke in October to the County Board of Public Health. So our public health officers have been amazing, but their overseeing board in Wood County has been, well, the leaders there are actually anti-masking, and that was very apparent. They're extremely unhelpful, and that's available on YouTube to watch if you want. So understanding the value of your knowledge and expert opinion. So as I said, we think, oh, whatever Dr. Falk thinks is sort of her opinion, but expert opinion really matters to a community. Our patients trust us, they care about what we think, and we really have a lot of sway with them. And so our education and experience means a lot to a lot of people. For me, I'd never done research, but even if you haven't done that, even if you don't like epidemiology, even if you feel like you're underqualified, it's still worth doing. So I thought this quote was really fitting. So change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek. And no matter who said it, so is Barack Obama, but I still think it fits in our situation as healthcare providers that we're the ones sometimes that the world has been waiting for. And while it's hard, it's still worth it. So don't be afraid to try. Many times I felt I'm just not the right person for this. Someone else knows so much more than me. There's got to be somebody else watching masking compliance and school cases, and nobody else was actually. So I had never used Google Sheets ever, which is sort of like Excel. I was able to figure out how to manage a 5,500 person data set, fairly quickly. I taught myself stats better than I ever learned it in college. I successfully got 2 grants to help schools get what they needed. I talked to the media, and I feel like I'm helping to lead my city through a pandemic in an evidence-based way. So by getting involved, you can acquire many new skills in pursuit of your goal or whatever you're trying to do. So I think another important piece is to propose a plan of action. In my example, obviously, it's getting kids back to school, but it could be dentistry in your community. It could be a number of different things. So I think it's important to not be afraid to fail and to set parameters and reevaluate. So I think the sheriff and I had a bet that no schools would be open by Halloween last year, but we were, and we just thought it was worth it to try for the million reasons we know kids need to be in school. So something else we learned was that if something's working, don't accept stagnancy. So many people were very happy to just keep the middle and high schoolers in this hybrid 2-day-a-week model and just finish the year. But I think we knew there was ways to do it, and should we try, as us pediatricians were seeing mental health difficulties and people falling behind in school, like how do we just get their butts back in school full time? And so we came up with a plan to try and a way to monitor safely that it was working, and it did. So share what you learned. Something that we did that was very time intensive, but we would make weekly progress reports to all of the schools, sending to admin to disseminate to their teachers and staff based on what was the masking compliance at those schools, what kind of cases were we seeing. I'd make those fancy graphs and have a very easy to digest blurb about it. And I think that was really important to sort of help with our relationships. Additionally, there's physician COVID-19 Facebook groups, which sounds ridiculous, but you have to be like, they check your NPI number to be a part of it, and it's just a good camaraderie. You can kind of see what other people are seeing throughout the country. Anywho, I posted our findings in the fall about school, and there were so many physicians who were like, you have to publish this because we cannot get our kids back in school. And someone was like, I'll help you. And that was our senior author, and we were able to tumble out and do the CDC thing. And after the publication, literally 45 minutes after it was released, the leader of the Duke ABC group called me. How he got my phone number, I'm not sure. It doesn't matter. Congratulating us and offering his entire palette of help if we needed it. UW-Madison, we had phone meetings with the CDC epidemiologists who wanted to know how we did what we did, like what we were doing and how they could do it, which I thought was mind-boggling because I'm a lowly pediatrician in central Wisconsin who made this all up as far as our methods. And we talked a lot with local and state leadership. So it really made a difference and it was worth it to share what we learned. So a talk like this would not be, I guess, complete without a talk about the challenges that we faced, and not to be the Debbie Downer, but just to show that there's challenges everywhere. So I had several new systems to navigate. The school administration and public health, they learned to trust Dr. Olson and myself. So we made ourselves very available. We showed up all the time. We'd reply to their emails, go to meetings. It took a very long time for us to build rapport. We made some mistakes, like many times teachers would email us directly and want to talk to us about their fears or we can't go back to school or whatever. And we learned to follow their hierarchy going through admin, which ended up being the better play there. And now public health and the school admin at WRPS, we're good friends now, which I think has been really interesting. Secondly, the publication world, it is cumbersome, extremely frustrating. I have no infrastructure as far as a big university system to just handle all the editing stuff. I don't have a stats person. So we were accepted about 2 weeks prior to publication that they had us, with our publication date. And despite that, we had endless, every night rounds of editing where there'd be 5 of us on, tackling all these comments that were like cyclical. Like one group would say we should change this, the other one said it should be the other way. I nearly quit. I was just like, what are we doing? This is wild. I have no bandwidth for this, but reached out to the CDC. They gave me a little cheerleader and mentor named Peggy, who apparently is very high up, and she said, it's fine, just keep going. That was a huge challenge with it too. Public backlash has been very hard, I think. So when we were doing Facebook posts, and then when the study came out on the CDC's website, they posted it, and there was extraordinarily negative comments. I know a lot of those are trolls or whatever, but it's really hard to read that when you have 800. For example, when the CDC released our study, put it on their Facebook page, the first 800 comments were how only 7 kids had to die. Nobody died during our study. I mean, there was a lot of really difficult things to read. In those surveys we sent to teachers, we would have a comment space where they could write questions or concerns, and we would try to put them in buckets and answer them. And some teachers were leaving extremely negative comments weekly. I'm sure it was the same 6 people or whatever, but that was really difficult for me to be putting so much time and effort into it, and them saying that this is totally useless. And at one point, one of my medical students, who's now a resident, said I couldn't look at the comments anymore, that she was going to do all the comments, put them into buckets for us to address as buckets, like I worry about X or, those sorts of things. So I didn't even have to read the commentary, which I took her up on for a time. Opposition and verbal abuse at the school board meetings. This was crazy. We went in May, Dr. Olson, Sue Comferman, the public health director, and I, to advocate for continued use of masks for the last 3 weeks of school because we know they work, and just let's get through this silly school year. And there was a very large, and Dr. Liebert was there too. We had a very large anti-masking group there. When the board would ask us questions, we'd be booed, heckled, accused of child abuse, accused of all, it was ridiculous. We actually couldn't leave, didn't feel safe leaving. We had to listen to the financial report. I have other things to do on a Monday night, but had to listen to the financial report because we didn't feel safe leaving. We nearly called for police escort out. So it was really troubling, and we haven't gone back since. We've communicated with the board, but not in person. And have to make a thicker skin. Sticking to evidence-based stuff and believing what you're doing, I think, is very important. Another thing I haven't touched on is finding time. I struggle with this sometimes. I am not an academic, but I am a full-time pediatrician. I take Q4 hospital call. I'm actually post-call right now. And I have 3 little kids, as you saw earlier in my presentation. They're age 7 and under. My husband runs a private practice optometry practice. And so I have 0 protected research or academic time. So meaning if I, do anything, it's going to be bedtimes, weekends, during nap time. Obviously, most of us do, I have an RVU-based practice. So if I block slots to work on stuff, if I block for meetings or phone calls, that's obviously lost revenue. And I know revenue and RVUs are not everything, and a lot of things matter, but when it's an 18-month plus project, it does add up there. So that is something that I've grappled with. I guess by definition, I'm a really efficient person, so I think that's been helpful. Perhaps this isn't for everybody, but it has been a definite variable for myself, and I've been better at learning to utilize trainees, medical students to delegate, which I'm still not good at, but I am getting better. So finally, dealing with my own biases as far as challenges. There are, quote, anti-maskers and anti-COVID people at every turn. You guys know this. Not to tribalize things, but I think, we've all become very entrenched, and it's hard when us as scientists and physicians are seeing the carnage and knowing what works and how we can do life safely with a vaccine and masking. And you know how this goes. These groups got a lot louder as the pandemic got worse. And they seem to be thwarting everything we were doing. And I think what's really hard is to not feel biased against them, or what else is hard, I think, too, is being like, look, I have evidence, I'm giving you just data after data. How can you possibly watch a YouTube video and be as qualified as I am? So a lot of those types of things are really hard to grapple with. And obviously for those individuals, you're not going to change any minds, but still struggling with that. I personally struggle with the role of politics in this biological event. Obviously, it's extraordinarily politicized. I struggle with religion's role in this, and some of the religious groups that have seemed to thwart the pandemic response. But obviously, we as scientists and medical providers need to do what is right, and right is obviously a charged word, but what is evidence-based and how we can protect our community, even if it's protecting them from themselves. So all of that aside, no matter what the challenges are, make it worth it. So there's so much opportunity for work at a local level. So problems seem so big and systemic, like how can I fix the political divide? Well, I can't, but I can work locally to make this a science-based thing, kind of presenting evidence, talking with all the patients that come through my door, and kind of going from there. There's a lot of opportunity for professional and personal growth and development, and don't lose sight of the primary objective. So for me, whatever that objective is for your project, but for me, it was keeping my kids in school and keeping them safe. And the results helped other kids get back to school safely too. So finally, you can make a huge difference. Even if you have little working knowledge, you know more than you think. And all of us, if we've gotten to this point, you have the brain power to figure out whatever you need to. You can teach anything, you can learn anything. Our community needs us and they look to us. There's tons of challenges, but just stay evidence-based, make as many connections as you can, and just jump in.